so I'm going wireless. Hopefully you can hear me okay. How's that? Good? Okay, so I'm going to hopefully keep today fun and interactive. I'm also, if I get a chance, going to do some interesting interaction with some poor volunteer at some point. But I'm going to give you a different perspective on the visual system. There's a QR code, by the way, on the cover slide. I'll make sure that Teresa sends out a link to everybody so you can download the PDF of the slides, plus a zipped folder with the original PDFs of all the research papers I'm going to talk about. Okay, so that way you don't have to go searching online. What I really want to talk about is the functional aspects of vision, because to me, eyesight and vision are different. Eyesight is what I read from the acuity chart. Vision is how I process what I see and how my oculomotor system responds to what I see. They are different. It's same church, different pew. And I think optometry has done a disservice by not, it's getting better, I want to be clear, it's not bashing my own folks. They've done a disservice by not going beyond acuity for certain types of cases. For people who are not injured, don't have a learning issue, it's not as big an issue, a routine eye exam is perfectly fine. But you have to do a deeper dive on concussion patients, especially post-concussion syndrome. Those ones are more symptomatic after a month, and also children who have, I want to be clear, eidetic reading problems. So dysphonetic is absolutely speech paths. You have to look at phonemic awareness, but oculomotor dysfunction is really key to look at in kids that have good phonemic awareness, but they still have things like tracking issues. They can't remember what words look like, so their sight words are down. These will be the kids who actually overly phonetically spell. So future is F-U-C-H-E-R. Future, that's how it sounds, but I can't picture the word, right? I'm going to do a demo before I launch into some of the slides. I'm going to pick somebody here in the front row as a target for me to look at. So if I'm looking at my finger, and hopefully the people at the back can see this, because I've been told this is cool, and I was told to do this 4 times last night at the reception for the dinner, and apparently people like this, I'm going to do it again. So if I'm looking at my finger, and I see 2 of you in the background, which by the way, we always see 2 of what we're not looking at, unless you're strabismic or you're suppressing one eye. So if I'm looking at my finger, I see 2 of you in the background. If I look at you, I see 1 of you, and if I pay attention, I see 2 of my fingers. Physiological diplopia, so double, but it's normal. So I look at my finger, and so first of all, I should be able to converge right to my nose, or do a simple test. Your images get further apart as I do that, so it's central peripheral visual interaction. If I get to about here and I take away my finger, I can hold you double. If I can control the periphery, right? I can make you go further apart. My eyes now are going in. I can let your shoulders touch. I can let your ears touch. I can make you slightly double again. This is the cool part. I can look at the left image, and I'm not going to make the left image move. What do you notice? Right eyes in. I'm going to right easy. I'm going to bring it back, hold it, look at the other image. Now I'm going to make the other image move. Now on the left easy shoulder. And I can vary the angle. I can put it way over there onto the desk, I can bring it back here, or I can slowly allow it to come back together. So here's my comment. Who's in charge of the system? Brain. Has that got anything to do with glasses? Right. So that's just the prelude to wake up after lunch because we're all in that kind of slump. So I like to show this slide because when people see this slide, they always go, geez, is this guy trying to compensate for something? And I always like to contrast that with, I was in a motor vehicle accident at age 8. I was knocked out of commission for 2.5 years. So I had a speech impediment, my SCMs were contracted, my head was gone forward, my speech was off, so I have great respect for speech paths because I did work with them extensively. But what was interesting is the speech issues were heard, the vision issues got missed. So I also saw double for 2 years. So when I would read, everything kind of went double, and one went higher. One image went higher and rotated. And I remember turning my head to use my nose to block one eye and holding the printer over here. Got this for 2 years. I'm sitting in, and my dad was in the Army, so hence the Army background. And what was interesting is my dad, we went through, I think the count was 11 optometrists, 2 ophthalmologists, all of which said 2020 is fine. And I remember the 14th one, who was a military optometrist, which was kind of interesting, picks up a pen and says, have a look at the pen. And I just said, which one? I said, what do you mean, which one? I can see 2. There's one here and one here. It turns out to my dad and goes, you're wondering why I can't read. Now, I want to be clear. I'm not saying that oculomotor dysfunction or oculomotor function alone is responsible for reading. Absolutely not. But if you see 2 of everything on a page, I'm pretty sure that's a barrier to reading. Right? Let's all be clear about that. So this, in Ireland, you're not considered much of an Irishman unless you can either play a musical instrument or quote poetry, so I'm going with the A's. Education is not the filling of the pail, but the lighting of the fire. I did optometry because I was actually pretty annoyed after I finished optometry because I thought I was going to learn rehabilitation, and I didn't. I learned how to be a good eye doctor and prescribe glasses and check for glaucoma and check pressures and do visual fields and check the anterior segment, all that fun stuff. prescribing antibiotics and steroids, but nobody talked about rehab, which I thought was kind of crazy, given that, I won't ruin the slide, you'll see how much of the brain is primarily neuromachinery for vision, right? So this has been a 25-year journey for me that's taken me through three countries. I really appreciated Dr. Rathbone's lecture earlier when he started talking about the IPRGCs, the intrinsically photosensitive ganglion cells. I'm going to talk about that more, because I think there's more and more coming out to say those are important, we need to pay attention to them. And part of my PhD, which I always joke stands for poor, homeless, and destitute, because very you make money, don't do a PhD. But what I spent 4 years on, what I do appreciate, I had time to think. I had time to sit down and study papers and look at anatomy and try to piece together structure and function, which I think is something that we don't do enough of. We see something and go, that's interesting, but we don't really look in the anatomy to go, why is that happening? Right? That's really important. So, I don't know if, so John Flanagan, who was my PhD supervisor, he's now the dean at Berkeley. I don't know if he's trying to scare me on day one. He's like, here's the visual system. All these boxes represent a different part of the brain, so the frontal eye fields area, MST. These are all different visual centers in the brain that perform some aspect of visual processing. I'm looking at that going, you gotta be crazy. This looks like an electronic diagram or something like that, right? So then you start to look at the literature, and this is one of the classic Feldman and Van Essen papers. It's a 1991 paper. It's an old one, but a good one. And the question they wanted to ask is how much of the brain is primarily visual machinery? Their answer, conservatively, 40%. Conservatively, right? So then you kind of look at, you look at this from the glaucoma world. Anyone in the glaucoma world will tell you, if you run an OCT or an HRT and you look at an optic nerve, it's astrocytes glial cells. It's not like brain tissue, it is brain tissue. So you could argue the eyes is any part of the brain that moves. It's a very different way to think about the eyes, right? Then you start to look at all of these areas are involved in what? Simple convergence. You take any one of these out, convergence fails. That's why near point of convergence testing is such a sensitive test. The problem is, if you have a defective near point of convergence, where's the problem? Good luck. It's a serial pathway, right? Sorry, it's a parallel pathway. So that's just from the anatomy. So I'm going to show a lot of slides. I'm not going to go into detail on every slide. Some of them I'll just show to say, here's the research. If you want to delve into it, you can look at the folder that I'm sending along. I want to spend more time talking about cases, but the research is there. I fully appreciate the need to do more. But I always joke with my patients that the eyes are the only part of the brain that is truly moving. So that's a different way to think about things. My PhD kind of worked more on, if I say I did my PhD in visual psychophysics, how exciting does that sound? Like, boring as paint dry, right? But if I said I did my PhD in illusions, that sounds a bit cooler. Yeah, that sounds really cool. So Ramachandran, he kind of made his name by the mirror box, phantom limb pain. Right? So you lose a limb, you've got pain, you put a mirror box on. Is that not vision? That's pretty cool. So vision is a pretty dominant sensory system. It can override pain potentially. So what's interesting is when he reads, and if you get a chance to read this book, I would highly endorse it. Fantastic book. What he says is, actually, real science is more like a fishing expedition, more than most of my colleagues would care to admit. Of course, I never say this in NIH grant applications, but most funding agencies still cling to the naive belief that science is all about hypothesis testing and carefully dotting the I's and crossing the T's. God forbid you should just try to do something entirely new and that is just based on hunch. If you read his TED Talk's hilarious. He'll say, I got a couple of $1 million from the NIH and we dealt with phantom limb pain with a mirror box that cost me about $10. Right? There's a lot to be said for not trying to build a spaceship to cross the globe. Right? So illusions are very powerful in that they can reveal kinks in the armor of sensory processing systems that we can potentially take advantage from a rehabilitation standpoint as well. This is one of my favorite illusions. Not fun for concussion patients. So anyway, right? So by the way, is that not a visual effect? Any post-concussion patient who looks at that, they go, that is called the VDT test. Mary Bowen came up with that test in 1972. Instant screening. You want something that takes you 2 seconds? Show that, right? So if you look at the blue star, I'm going to come out of the way so you can actually see it. We're going to set off the sound here. So if you look at the blue star, there's a red dot that's going to appear here. I only want you to look initially at the blue star until I tell you to switch. Okay? So you're looking at the blue star. Keep looking at the blue star. Which direction is the dot moving while you're looking at the blue star? Go diagonal, right? Now look at the red dot. Ooh, there it is. Right? So, what's happening? So I'm looking at the blue dot. It looks like it's going diagonal. When I shift my fixation back, the red dot, when I look back to the red dot, it's actually going up and down. So the background patterning is overriding the motion vector that I think I'm seeing. And the crazy thing about this is, even when you understand the illusion, you can't override it. It's there, right? So then you can talk about area MT, motion processing, receptive fields, IPRGCs. There's a whole bunch of things that come into play there. So this is kind of the world that I lived in, where I was fascinated with illusions because they were helping me to understand how our brain constructs what we see. So in the vestibular world, we always talk about peripheral vestibular, central vestibular. This would be the equivalent of vision in the eyeballs, vision in the brain. We're talking about central visual, not central visual field, but central visual brain, right? So I'm going to show you, this might seem basic, but sometimes you got to get back to basics. So I'm recording somebody sitting in the chair in my exam room, and I have the 20/20 line up 20 feet away, which is usually on the electronic charts. It's like 5 little letters on a chart 20 feet away. Watch his eyes and tell me, do you see his eyes move?
Okay, so can you read the 20/20 line for me? ORUFA.
So he blinked at the end, did his eyes move? Yeah, right? Okay. Here is what he's reading. So he's reading in his head, not out loud, but watch his eyes.
Read the first paragraph for me in your head.
Pretty obvious they're moving, right? Okay, so based on what you just saw, the 20/20 tell us anything about how the eyes move. What do I have to do to drive? What do I have to do to read? What do I have to do to, I'm driving, I check my speedometer, I go back and forth, I go up and down the stairs. You think I'm making eye movements? Right, so if somebody sees 20/20, does it tell us anything about how their eyes move? No, that's a really big gap in eye care right now. We're not really looking at eye movements anywhere near to the depth that we should be. So, we published this is about a 10-year-old paper, and we made a point of publishing this in a medical ophthalmology journal because we took 50, and this was not on post-concussion patients, this was on kids who had IEPs, so they had a learning difficulty specific for reading, and they were specifically, dysphonemia was ruled out. So it's like their phonics are intact, their scores are good, but they have tracking issues, they have to use their finger, they have to go down one line at a time, right? Because we work closely with speech paths, we appreciate their angle as well. So what we did, we decided, so this is a PhD now, I want to see what their eyes are doing, I want objective data, right? So these are 4 infrared cameras on the bottom. And this is a typical plot of what you saw in the control group. These are age 6 to 16, right? And the red indicator shows the average position of both eyes as they're reading. And what's nice is you kind of get some data. So this is 96 fixations to read 100 words, 3 regressions, or every 100 words we have to go back. We all do that occasionally, it's not abnormal. And this is the percentage of the time that the eyes track together, 99% cross correlation, right? Here is what we typically saw. This is not a cherry-picked one. This is typically what we saw in the other group that were reporting tracking errors, things like that. So what you see, before we even look at the numbers, what do you notice about the pattern? There's a lot more back and forth, right? Now, what's interesting, you go over here, 448 eye movements to read 100 words, 145 regressions to read 100 words. Here's the kicker, the cross-correlation only dropped by 15%. What does that tell us? A little disruption in binocularity decimates tracking. Doesn't take much, right? So now imagine your tracking is off, and now your accommodation is off, so you're having trouble holding your accommodative system in check, and you're drifting in and out of focus. What's that going to do to your comprehension of what you read? And then you get these people who go, I read 3-4 paragraphs, I get to the end, I have no idea what the hell the paragraph is about. I got to reread it 3 or 4 times. But yet when I listen to it, I understand it way better. Well, what are you avoiding when you listen? Vision. Okay, so let's do a little experiment here, and you can all kind of do this in your heads. I'm going to pull up a page, and I want you to start from, it's going to start from the top. Bobby the Bear wants to read, right? So you're going to read from the top, read that in your head. There you go, keep going. Keep going. Keep going. Come on now, try harder, right? So you can imagine if I pushed you to read that whole thing to the end, and then I went to the next slide, I said, so what was the story about? Right? So vision has an impact, of course it does. So this is some of the data that we got from the paper. This is a fancy graph which I won't get into right now, but what you can see there is, this is called Vergence facility, which is basically a 12 base out, 3 base in. It's a prism that makes you go double. So what I love about that test, there's an objective confirmation of a subjective response. The patient sees double, you should see a fusional reflex, pull the eyes back together. And you can do that convergent, divergent, convergent. That's been published in the literature. Ron Ball actually was in Oakville, published that 15 years ago. Right? So what we found in the pediatric group, again, not concussion, we're getting there. This is the IEP group, this is the control group, and I'll save you the hassle. Every single ocular motor metric was significantly reduced, apart from astigmatism. There was no significant difference between the two groups. But you had a higher hyperopic or long-sighted prescription, so these people tended to pass 20/20, but have more trouble focusing on close, especially in kids. And you also had a higher CISS score, so that's just a standardized symptom score, right? So, and I love that phrase from Don Head, nerves that fire together, wire together. I'm gonna dare tweak that statement a little bit. Nerves that fire together consistently wire together, because if it's inconsistent, you get the opposite, you get inhibition, the system shuts down, because the brain doesn't know what to do with the information, right? So, we'll get into the rock analysis, that's a whole bunch of stats, which is always fun. So, yes, there has been some NIH-level randomized clinical trials in pediatrics, not concussion, but specifically for symptomatic convergence insufficiency. They have shown that visual rehabilitation is highly effective if it's done in-office reinforcement home therapy. If it's home therapy alone, no better than a placebo. The data was very, very clear. And I love that actually talking about the nocebo and the placebo effect this morning. I completely agree with that. I think there is an effect on how you counsel your patients. So the CITT study came out in 2008, and then in 2012, there was a follow-up study done, also funded by the NIH, that showed that academic behavioral scores that were reported by educators and parents, when you picked kids that had significant convergence insufficiency and you followed the protocol of the CITT study, you saw a significant improvement in the academic behavioral scores from both the parent and the educator. So like, these are published. Now, so then you start to go into brain injury and you say, okay, well, wait a minute. If I have ocular motor dysfunction, how do I get it? There's other more minor factors, but the two big camps that I have in my head are, number one, I have a concussion. Okay. Number two, developmental factors. If I'm preemie by 3 weeks or more, birth weight less than 5 pounds, 5 ounces, there's a lot of papers out there suggesting that infantile esotropia, so this is a full eye term that you can actually see, this is not convergence insufficiency. Ocular motor dysfunction is way more common in someone who's preemie or low birth weight. So if you have somebody who's got that history and then they have a concussion, interesting, right? Okay. So I think we need to be aware of those. So obviously we've gone through a lot of the stats this morning, but what's interesting, Zenek, who's in Chido, I believe, the Children's Hospital of Eastern Ottawa, I believe is what that stands for. Really nice guy. Talked to him actually yesterday or two. They're estimating right now 1 in 7 the emergency room visits are pediatric concussions. And then they're saying over 59% of these are still symptomatic after a month. So they're meeting that criteria for persistent post-concussion, right? And then you got all your symptoms here, obviously the percentages are all there, light sensitivity. My explanation of light sensitivity, and I've asked Eric Singman, so Eric is an MD PhD, he was the head of neuro-ophthalmology at Johns Hopkins, and I can't remember the other guy's, Jan Gajar, he was at Stanford, also an MD PhD. Both of them are just unicorns in the neuro-ophthalmology world. And I asked both of them, really smart guys, I said, what do you think is the cause of photophobia? Why do we get light sensitive? Seems like a really basic question, right? They both had opinions, but they completely disagreed with each other, which I thought was cool. And then I stepped in and I said, well, here's my simplicity. I'm Irish, I'm simple. I like to keep things as simple as possible. I think light sensitivity is light information that the brain can neither organize nor ignore. I don't know what to do with it, but I have to register it as a signal, period. Right? So, elegant, simple, makes sense. So, I'm going to show a video here now. If any of you are sensitive to seeing accidents occur, turn away. But this is interesting. This is actually from a case that we dealt with a couple of years ago. We have full permission to show all of these things. This also speaks volumes to why you should wear a bloody seatbelt. Watch this person in the back. This accident occurred at 30 kilometers an hour. Right? See in a second. This is in real time. That's real time. Right? 30 kilometers an hour. This was labeled a mild traumatic brain injury. How much whiplash just occurred there? Right? NPC, we saw this patient, NPC was 1.5 meters. And just for clarity, you should be 8 centimeters or less from the bridge of your nose. 1.5 meters. But the MRI was clear, the CT was clear, nothing wrong with it, right? So what's interesting is, this came out of UPMC. This is Michael Collins and his group, doing some really good work down there. And what's interesting is when they look at ocular motor scores, you obviously get your 6 vectors. You got anxiety, cognitive, migraine, ocular, vestibular, sleep. Ocular motor is correlated heavily to cognitive, migraine. These are the highest ones. The highest score, the highest raw score was ocular motor, and second was migraine. So out of all 6, ocular was number 1. Then you do an ROC curve to say, hey, if I take a bunch of controls and a bunch of concussion patients, which symptoms are best at sifting out which are controls, which are concussions? Migraine is by far the best, but the next one in is vision. So I'm not dismissing the other areas, but I'm like, you've got a lot of neuromachinery. I would argue vision is the most dominant neurosensory system that we have. So the fact that we've done it down to acuity is kind of idiotic. So I'm just going to say it, right? So Then you start to look at the stats and you say mental health, this is kind of the whole theme of the conference which I love. Let's look at kids. So among children aged 5 to 18, concussion is associated with increased risk of mental health issues, psychiatric hospitalization, self-harm, published in JAMA Open Network. This one, from the CMAJ, it's a 2016 paper, 3 times higher rate of suicide compared to the general population. This is a really damning statistic. Half of these patients had visited a physician in the last week of life. So the narrative that these folks are not looking for care, nonsense. They are. I don't think they're getting the proper triage from the system. And I say the system including us, everybody. Right? We need to find a way, I'm not saying I have the answer, but we need to find a way to triage the right patients to the right people at the right time, in the right sequence. I think that's really important. And then down here, this is interesting. This is a fairly recent study. This was just published 2 weeks ago. From 1 year to post-injury to 6 years, results support consideration of TBI being a chronic ongoing condition requiring ongoing rehabilitation and monitoring to optimize independence and quality of life. We know the average time for vision rehab that we see patients, 5 years post-injury. 5 years. Okay, we do a lot more if we saw in a year. Right? Average is 5 years. This is Christina Masters and Mitch Scheinman did some really good work in this area. So they looked at 100 patients with post-concussion syndrome age 11 to 17, and they only looked at 3 metrics: saccades, tracking, accommodation, near-far focusing, convergence 3. And it's easy to show it as a Venn diagram. If you add all those numbers up, it comes to 69 out of 100. 69% of them had at least one of the 3. Right? 46 had more than 1. 14 had all 3. Right? And Christina Master, I believe, I can't remember where she is, but she's doing some really good work with Zenic in Ottawa. I know they're connected. She's not in Canada, she's in the US, but she's done phenomenal work in this area. Then myself and Mike Hutchison at the University of Toronto, we took a whole bunch of athletes that had played sports and may have had a concussion. This is interesting. It's like, yeah, you may have had a concussion. And we did a baseline ocular motor screen just looking at convergence, saccades, and accommodation. And we found about 1 in 5 of them, 20% failed our baseline testing. And if you did a BID score, which we'll get to, it's a brain injury vision symptom survey, the ones that failed the ocular motor testing, most, if not all the time, had a really high symptom score on the BID question. So are these people set them up for another injury while they're already technically, I think, already should be on the field? Probably. And my hat's off to the University of Toronto. They actually went ahead and they published this, knowing that we've got 1 in 5 of our players that probably shouldn't be on the field. This is Dave Patowski. This was a co-authored paper of psychology and optometry. What did they find? They found that if you took a group of controls and concussion patients and you did a bunch of ocular motor tests and you failed those ocular motor tests, you were nearly 11 times more likely to be from the concussion group as opposed to the control group. Interesting. And then over here, this is persistent post-concussion syndrome is underdiagnosed in the pediatric population. 25% of children admitted to the emergency department due to NTBI may suffer from persistent post-concussion syndrome. Screening guidelines should be implemented. Well, okay, everyone's saying that. What are they? But I agree. But let's get to the ground level and get into the nuts and bolts and go, why are we not looking at vision as the most dominant sensory system here? So this is where it gets fun. So my wife thinks I'm a big kid, and I think she's right. But there's a ribbons, believe it or not, at the base of Niagara Falls. It's got a rotating, I love this thing. So I went through it like 5 times now. I think I'm going to puke as she stopped. So I'm walking, and it kind of looks like this, right? So as you're walking through it, it's rotating. And obviously, I'll never take a concussion patient in real life and put them through this. It would not work out well. But this is somebody who's not a concussion patient. It's rotating slowly clockwise. Watch which way she falls. What's really cool, you stop the tunnel, you rotate the other way, watch what happens. Interesting, right? That's your peripheral visual system. By the way, that's how much of your central field that you use for acuity. 20/30 acuity or better represents 6% of your central field. Let me turn that around. 94% of your vision has nothing to do with the eye chart. Which one made her fall? Is that vestibular? Right, so this is the way I tend to look at things. Vision, vestibular, proprioception. So when I say proprioception, it's not just my feet are touching the ground, it's also proprioception in the neck. There's a whole bunch of other, I feel where I am in space. And by the way, there's new evidence I'm going to talk about that says there's this thing called ocular proprioception that we are completely ignoring. Jan Brunick out of Norway has come up with some phenomenal papers showing we're ignoring that and it's a big deal. So I want you to think of this like a 3-legged stool. If I take away one stool, the leg falls. Right? They're all important, but what did the tunnel prove? Even if these two are intact, And as I know, Dr. Burge will say to me, vestibular is really cool because it's fully developed at 48 days gestation, right? Cool. The visual system is not completed until 2.5 years post-birth. We do not see 20/20 acuity until 2.5 years post-birth. Doesn't that make sense if it's the most dominant system? It takes longer. However, there's one part of the visual system that is fully monitored at birth. Area NT. Well, remember, it's also called V5. Why is that important? What does area NT V5 control? Peripheral motion processing. It's the only visual area fully monitored at birth. You think that has anything to do with the VOR reflex? So I look at something, I move my head, the fact that I don't feel dizzy and fall over. Nature put those two together at birth. It said, I don't care about acuity, I want to make sure the VOR is intact at birth. So what the rotating tunnel shows is that vision can override these two. Here's the problem. Vision can override these two even when vision's the problem. So even when vision is misbehaving, you can still override those two. Now, Brenda will also say, sorry, Brenda's my vestibular inner ear gal. Brenda will say, yes, you're the younger brother, I'm the older sister. You're usually the problem. But when I'm the problem, I'm really the problem. And I would agree 100% with that, because when vestibular is a problem, it's like everything else gets more difficult, right? And we'll talk a little bit about vestibular, but I'm kind of teeing it up at some point. You should probably get Dr. Virgin to speak, but she can speak functionally about the vestibular system. So, again, I want you to remember, 94% of your vision has nothing to do with acuity on the X-ray. Important to remember that. So, this is where we're going to turn down the volume because it's going to be pretty loud. So, a couple of clips from patients, right? So, this is, Dad's recording this at a hockey game. His son's about 16 here. And I want you to watch this guy right here. So he didn't see it coming, right? Exactly. So he doesn't see it coming. This was not intentional, actually. He falls, hits the ground, hits the back of his head, then you get the double tap and roll. So he's rolling. His head is now hyperextended under his body. He's got a neck hyperextension injury. He's got hit the visual cortex right back here. So this guy lands in my clinic about 1.5 years after the injury, sooner than most of my patients, right? This is how he walks in. Mom's holding his cane, by the way. So he's walking with his cane. Mom's holding his cane. He's drifting majorly to the right. There should be down. That's okay. So he's moving to the right. Yeah, just turn up. So now. Now I want you to stop for me. And I want you to slowly turn around. I'm going to go to your right again in case you go. And now slowly walk back towards the door. This is him walking without his cane for 1.5 years, right? Did anybody bother asking him what the floor looks like? Yeah. Did anybody bother getting him to walk with his eyes closed and realize he doesn't lean to the right with his eyes closed? So vision's interference. Vision is either assistive or destructive. It's never in between. So he's perceiving the floor like this. He's orientating himself to make the floor look flat, which makes sense, right? Now, here he is with something mysterious called a prism, which apparently is voodoo, and nobody really understands. Here he is with a prism 10 minutes afterwards. And I guarantee you that's not a placebo effect. So what's interesting is, listen to what we say here. How does that feel? Better? Yeah. Feels a lot better. Cool. All it did is allow the eyes and ears to talk. That's it. Right? So, now, what's the purpose of the prism? It's not, here's the prism, here's a pair of glasses, you're good to go. Prisms are compensatory. The goal is to get rid of them. Okay? So when you do the visual rehab, again, nerves that fire together, wire together, what are you doing? This is him 6 months later without the glasses, walking straight. Right? So the goal is not to have them those forever. Right? So, and when we sent him back to the team that was managing him, you know what the diagnosis was? Spontaneous recovery. So I guess I should call myself Dr. Spontaneous now. Right? So to me, it's like, okay, I'm staying humble. There's a lot of stuff I don't understand about this. Can you imagine? And yes, we need randomized clinical trials, we need NIH funded trials. But as a PhD, I sit there and go, hold on a second. If I went home and my wife said, you know what, Pat? Dogs can talk. It's kind of, yeah, you're crazy. She pulls out her dog, puts him on the table, the dog starts talking. Is my next comment, I'm not going to believe you unless I see a randomized clinical trial that's double-blind institution. Or is it like, holy crap, I got to explain why that dog's talking. There's a role for evidence-based, but there's also clinical experience. You see something that is that significant, how on earth can you ignore it? Right? So, here's another case. This is Captain Murray ago. So he's walking, same thing, he's walking this cane. Right hand is extended, very spatially unsure, visually spatially unsure, you can see it. He's got a sense of humor, so he's like, imagine if I drank beers, so you would hear that sound. And I asked him to describe his vision, but listen to what he said.
Can you imagine I drank alcohol?
Sense of humor.
It's everything just I can't focus on anything.
Where did he just point? He's living. Okay, so he's got no sense of internalized motion. If he sits still and he closes his eyes, he doesn't get a feeling like he's bobbing. I know there's vestibular migrainers, that stuff is all really important, right? He's doing the stepping Fukuda test. He does not rotate. There's no vestibular hypofunction. Right? They're not sure what to do with him. By the way, this guy is 3 years post-injury. Already had a suicide attempt, married with 2 kids. Right? So here he is, 20 minutes later, with the yoke prisms. I usually go base opposite the lean, so he's walking with, he's drifting to the right, so it's yoke prism base left 3. This is him walking.
You said what, you're about 6'4"?
Yeah. This is crazy.
You notice he's moving his head now?
I'm too quick.
Because before, if he would walk and turn his head, he'd fall in the opposite direction. He was just grounded. He didn't tell me that till afterwards. So he's going to get to the end, and it's kind of cool because it was spontaneous, so I was going to turn the camera off. But he's like, no, hold on, keep going, I want to try something. No idea what I want to try. And I was kind of like, you should have told me this beforehand, because if you fell while I was recording,
Just slowly turn
what would
it
have
up.
happened?
Just don't turn too quick. Alright. That's
This time will let you record it for a second.
Yeah.
I'm gonna look this way for half of it and then that way.
okay.
This way is.
I'm not sure. I have no idea what you're doing. Go for it. Have you done that before? No, we're not. Right. So, if we can just use the laptop just for a second, because then we can just turn down the volume on the laptop. We need to. So, let me go back here. I'm just going to pull these side by side. Turn off the volume altogether.
Slowly. Try to stay.
Keep going. 20 minutes. The only thing that changed was his peripheral visual system. That's it. How are we missing this?
You know why he asked you to do that?
Right.
Because he's been through vestibular rehab.
Exactly. Yes. So again, I'm not saying vestibular rehab is not good. Hear me correctly. But if somebody, so his near point of convergence was about 50 centimeters. So if I have double vision and my visual system's off, does that interfere with VRT? Pretty sure it does. If I'm looking at something doing doing VO cancellation exercise, I'm pretty sure it interferes. So again, I'm not saying that's not necessary. I'm saying this is an important precursor in a lot of those cases that you've got to be aware of. You have to sift them out appropriately. So what's interesting is, we can back up again. So Dr. Semple, who's a neuropsychologist at St. Cat's, a wonderful guy, he was taking care of this patient. He calls me up and he goes, holy crap, what did you do to that patient? And I was like, I just did yoke prism. He's like, I want to come to your office and record a QEEG with him without. I'm like, sure, knock yourself out. Like, I won't do them, but that sounds cool. So he shows up in the office, and what's interesting, without the career, you can kind of see here the top 4 or 5, you start to see the variability. And all he's doing is just looking at a target, he's doing nothing else. Stable fixation. And you can see it becomes more variable. That's not very repeatable, it's kind of all over the place. And the more you record it, the more erratic it gets. Right? So what's interesting is, then you say, okay, what's he like with the rhythm officer? Just got the glasses on, doing nothing different, he's looking at the same spot. Zoom in, you see one blip, and it's like pretty consistent the whole time. Now, I am not a QEEG expert. I asked Terry, what does that mean? He shows me this stuff, and he assures me it means something. He's like, you've never seen that. That is insane. So that's kind of cool. We're getting that validation objectively through QEEG. So again, that area is really ripe for research, I'm pretty sure. So this is a pediatric case. So she cracked the back of her head off of concrete in the playground. And she's literally describing how the floor looks. I said, describe the floor. There it is. And she gets up, and she's going to put a lot of pressure on mom's hand. She walks towards the entrance. You see what happens. So she's very unstable in gait. She's very unstable. And you notice she's got a very high plus prescription. You can see her glasses. So when I talk to mom, this is a kid with an IEP in place already before she came to this. So probably a shaky ocular motor system. Most likely, we don't know
Right, you know,
that.
straight away.
Straight away, smart kid, first thing she does, makes the base vibrate, she knows she's going to go to the left. This is her trying to walk, right? So,
Okay, so this is where symptomatology which occurs in this.
yes, and that's down the line.
Because she's looking for the water.
You want it's the same day, within a half an hour. Right, but it's voodoo, right? Good morning. So, that must be my third case of spontaneous recovery. So what's interesting is when we start to look at area MT, again, you start to look at the neuroanatomy. And you're looking at area MT, which is motion processing. And you look how central it is. This is the thicker the line, the heavier the neural input from that part of the visual system. This is your magnocellular system, which is primarily feeds into area MT, and also to the brainstem, which I'll talk about, the superior collicus in particular. And area MT, as you go from V1 to higher cortical areas, you start to get much larger receptor fields. So area MT deals with a massive area of the periphery, and IPRGCs are functioning in a similar way, similar to what Dr. Rothman was talking about. So what's interesting is area MT is also the only area fully myelinated at birth, and the vestibule is 34 to 48 days gestation, which is fascinating to me. Hebb's law again, and there's a part together, likely not a coincidence. Vision develops from the periphery inwards and then locks with vestibular at birth to establish the VO organ. That's really important as from a rehab perspective to understand. Vision and vestibular go together, hand in glove. Right? That's why, like the V's vestibular, what does the O stand for? We tend to ignore the O part. Yeah, well, they have eyes that are what they're good, and their retina is good. Yeah, that's important. We want to rule out ocular pathology, but we have to look at the dynamic visual skills of the patient. This is also a TMS. This is really cool. I would love to be part of this. They took transmagnetic stimulation and they literally knocked out area MT temporarily. So they inhibited area MT, and the participants in the study couldn't figure out. They could see motion in their periphery, but they couldn't figure out what direction it was going. So it knocked out directional attention in the motion system, which is kind of cool. Right? Scary, but cool. Then we talk. This is kind of where I've gone down a rabbit hole. Cerebellum. So if you look at the cerebellum, these are all the most common areas. This is John Gajar's slide from Stanford. These are the primary areas of diffuse axonal injury for most post-concussion single cases. And this stuff is talked about a lot. This isn't. The cerebellum, this is one of the points of maximal diffuse axonal injury. So a couple of points about the cerebellum that we tend to ignore. 88% of the development of the cerebellum occurs within the first year of life. Point number one. Point number two, 75% of all brain cells are granule cells in the cerebellum. The cerebellum seems to be particularly involved in temporal organization. Time. I can move my eyes and my head and my body to the right place at the right time. Right? It's a brainstem function. It makes sense. Superior colliculus, balanced through vision. Inferior colliculus, balanced through vestibular. Look how close they are in the brainstem. Interesting. Then, so if we kind of go back to this and we say, how on earth did we miss this? What's interesting is Jan Bruneck, I mentioned his publications from Norway. So he has published extensively in the Scandinavian Journal of Ophthalmology and Vision Science. He's prolific. And his lectures are always interesting. I had the pleasure of listening to him lecture in Montreal about 6 years ago. And his opening line will catch you off guard. He's like, my patients are generally different to yours, mine are usually dead. I was like, cool, this is a really good lecture. So he's an anatomist. He looks at structure and what's connected to what and what inputs to what. His lectures are really interesting. And what he found was, he was taking cross slices and he's really looking at inputs to the cerebellum, and a couple of things kind of came out. Purkinje cells, these little black cells up here, Purkinje cells, which are the main efferent cells of the cerebellum, are found in the cortical regions of all three cerebellar components. Visually related information, proprioception, and vestibular input are cross-referenced to neural interactions between these three areas, forming the basis for maintaining equilibrium, balance, and fine motor control. This neural integration is vital for fluid and accurate eye movement. And he talks about how the signal coming into the cerebellum gets degraded. So he says, for every one neuron that comes into the cerebellum from the vestibular system, it's about a 10 to 1 degradation. So if you have 10 neurons coming in, it gets condensed to one neuron in the cerebellum. If you have proprioception, you've got 1,000 neurons coming in, it gets condensed down to one neuron in the cerebellum. Vision, one neuron coming in, one neuron in the cerebellum. What does that mean? The cerebellum does not tolerate any visual degradation in signal. Pretty cool. No one buys down the eye doctor to do that, and he's going to agree with me here, right? So, I'm going to skip past this in the interest of time, but they're all in the hand. So this is Jan Brunek's really cool paper. So what this showed, I looked at the eyeball and said, hey, we missed something here. We missed that the global layer of the neuromuscular tissue around the extraocular muscles is one thing, right here. There's also an orbital layer of muscular tissue that extends from the extraocular muscle and attaches to the inside of the orbit. So his opinion on this, which I completely agree with, he says, we kind of missed that, and by the way, that's important for maintaining motility, spatial orientation, and perceptual stability. Seems to rely on extraretinal information, IPLGCs, about eye position in relation to the head and the trunk, even with the eyes closed. So what he's saying is, when I have my eyes closed, my body needs to know the position of my eyes within the orbits relative to my head and my body. Ocular proprioception. That's a pretty cool statement. And he's backed up with the anatomy. His papers are phenomenal. They really are the best I think I've ever seen. Then you start getting into neurovisual rehab. And yes, I'm going to put it out there. A lot more research needs to be done in this area, 100%. But what's interesting is, okay, we have fMRI. This was published in 2018. What did they show? If you take adults with symptomatic convergent insufficiency, pre and post therapy, the bull signaling shows a significant change. Pre and post. Then down here, vision therapy for post-concussion disorders. Ken Kafrida has published a whole bunch of stuff on this. And I'll let you read those yourselves. Yes, they're not double-blind placebo-controlled, but they're papers. And I think somebody mentioned Marshall this morning. There's an NTEI guidelines document from the folks at McMaster, and they actually allocated level evidence B to visual rehabilitation in one of the versions. And for some mysterious reason, in a later version, it disappeared. That was odd. Like, how can you be good in one version, not the next? So, vision therapy for post-concussion. This is Mike Galloway, Mitch Shiner. Convergent insufficiency and accommodative infacility were the most common diagnoses. Vision therapy had a successful outcome in the vast majority of cases. That completed treatment protocol, that's important. You actually have to complete, like any form of therapy, you have to complete it, right? Here it is. Sean Marshall's good at NAC. I thought this was very well done. If you go, what I liked about the appendix, they literally listed everything out. Like, here's a level of evidence for what the intervention is, and then A, B, C, and D. And if you go to section 10.10 down here, so I blew it up because I'm getting old too. And what they said in section 10.10, other functional vision changes, so other functional vision changes, so visual changes that we think are visual, but we don't know how they are. It's a polite way of saying that. Should be given consideration for referral to a qualified optometrist specializing in neuro-optometric rehabilitation for vision therapy. Here's the problem. Our profession currently does not formally allow specialization. We're in the process of doing it. I know because I was the head of I picked the crappiest time to be the president of the regulatory college. January 2020 to January 2022. Like, I couldn't. January 2020, I'm like, how hard can it be? I'm dedicated, I'm on the phone every other week with the Ministry of Health, it was really fun. So, right now, there is the FCOVD. So if you find an optometrist who has the initials FCOVD, you're a fellow of the College of Optometrists and Vision Development. It is a 2.5-year board certification fellowship training process, and you have to recertify every 3 years. It's not like you got it and you're good. So COVD.org is the website, so I'm not here to say, send it to me. I'm like, find somebody who's an FCOVD. There's 50 in Canada right now, and there's more. But a regular eye exam, I'm not bashing the regular eye exam, but in this population, a regular eye exam is nowhere near enough. It's not even close. This is the book chapter that I published with Dr. Singman. So Eric is the head of neuro-ophthalmology at Johns Hopkins. So he calls me up one day and he goes, hey Pat, I got asked to write a book chapter on monotraumatic brain injury and concussion, and I can do all the med stuff, but I go clean from the rehab side. You want to do it together. I thought that was really cool. And then over here, we actually published I realized the International Classification of Headache Disorders does not discuss vision at all. Think about that. It's 40% of the brain, the most dominant neurosensory system, and for headaches, we just ignore it completely. There's literally no mention of vision in the ICHD right now. So myself and Eric decided to write a paper, and we put that straight. So this is where we all get to. It's like, okay, all of the different professions are important. Physio is important. Vestibular is important. Doctors of audiology are important. Neuro-optometry is important. Neuro-ophthalmology, like all this stuff. But the question is, okay, how do we decide where to go? So this is a kind of a modified version of Impact that we use in our clinic. And I use it as a clinical tool, personally. I find it's very useful. Anyone wants to take this and change it and modify it into a paid product, be my guest. But what I do, 6 vectors of injury. There's your questions. So the grayed out boxes are where that question is not applicable. And what you do is you ask the patient the question, scale from 0 to 6, you fill it in, and then what you do is if you score a 6 here, you multiply it, you copy the 6 across here to the boxes that it applies to, and then you total up the score in each one of the columns. It tells me who I should be treating and who I should be getting out of my chair to somebody else. And I think that's important because there are some patients that need to see Brenda Verge, not me. If that patient's a vestibular migrainer and they have true symptoms of vertigo, get the hell out of my chair. Do that first. If there's a neck issue, get the hell out of my chair. Do that first. Because my job's going to be made way easier when that's dealt with and when the neck is dealt with. Vision makes a lot more sense. So it's like the best doctors I know never think they know enough, and they also know when to get others involved. As a clinician, your number one enemy, I'm sorry, I'm just going to say it, it's your ego. It's your ego. Right? You have to have tools here that keep you focused on what's best for the patient. Then if vision is high up there, you can do a deep dive. This was published by Henry Laukkanen in 2016. This is validated. It's called the BIDS questionnaire, Brain Injury Vision Symptom Survey. If you add up all the fours, the maximum score is 112. It's a 0 to 112 scale. Anything over 32 is a significant score. That tells you there's probably a significant oculomotor component to this here. So when someone says these things are hard to test for, no, they're not. I know it's a subjective thing, but what if you did this and just a very complicated test called a near-point convergence? How many of your concussion patients, when you do this, they go, ugh, can't do it. This is Vergence and Accommodative Deficits in Children and Adolescents with Vestibular Disorders. This was published in 2022. The conclusion was, yep, we see visual function deficits with a high frequency in patients with vestibular diagnoses. If they have one, they should be assessed for the other. They're that commonly intertwined, right? Again, not all of them, but a high percentage. So here's a case where, not going to do for time, we're going to take for time. Here's a case where it wasn't a vision problem. So this is an actual eye doctor who had vision therapy. It helped him, but he's like, a whole bunch of my symptoms are still off. So he came to see me as a friend, and I spent like 10 minutes with him, like, you see, right? So here he is, walking, with his eyes closed. Initially, you have a problem? There you go. So, yes, he's a concussion patient. He had 3 concussions in the past. Put the hearing aids in. Here it is. What are we doing? So, this is what I want to be clear about. What are the hearing aids and the Yoke Prism? What are they all doing? And by the way, have you heard of PONS, the one you put on the tongue? Okay. What are they all doing? They're augmenting the signal in the brainstem. Nerves that fire together, wire together. So, in my opinion, it doesn't matter how you get there. You're going to see different deficits in different patients. In one patient might be more vision, the next patient might be more vestibular, the next patient might be more, you need to use something like the PONS to stimulate things. And again, we need to learn a lot more about this. But I think we're all missing the fact that the cerebellum is key. Yes, cervicogenic, neck injuries, whiplash, all that stuff's important. And I actually think if the SEMs contract, you get a major issue with blood flow to the head, which is why exercise is showing to help, because you're increasing blood flow. But again, if the SEMs remain tight, you gotta get that depth, right? So this is the interesting part. So he's stepping Fukuda. Who here knows that test? Put your hand up. Right, that's usually that's a stepping Fukuda. Like such a simple test. Stepping, marching on the spot. Watch this.
Have you heard of the
This is Brenda.
walking on the
Yeah, stepping for good, we do it all the time.
Yeah, so try it. See, so I usually do like a whole.
Sure, absolutely, go ahead.
So he's got the hearing aids in right now. No rotation. Okay, it's not on a second.
Super. Now, take them out. Do it again.
It takes about 5 to 10 seconds, but you see rotation towards the hyperactive side. He doesn't know he's doing that. He's no idea. Eyes are closed.
Stop.
No idea, right? Now, what's interesting over here, he's got the hearing aids in. When he lies on the floor, he gets the feeling that he's floating. He gets that floating sensation, right? Watch what happens.
Okay, so breathe. You're doing this exercise because why?
So what typically happens when I don't have the hearing aids is I can't stay in this position. I feel like my feet are floating away.
So it feels like his feet are
That's why
floating.
I have this cross.
So process is that
Makes you feel like,
I feel proud of it, I'm actually good stay put.
okay,
Um,
but right now you've got
right
them
now,
in, so,
it feels really heavy, so
Okay.
I was almost like, I want to do this, because
Fine.
this is almost too much.
all right,
This is just not comfortable.
okay, so now take them out. And when you do that, what happens?
Yeah, right away, I lost sensation in the bottom of my feet, my legs just don't feel like the ground. They could be floating, and so that now makes me feel like, that's my back.
You rest your back.
That's my back, my feet are on the ground.
So there's the pond. So I mean,
Okay,
again,
I'm not gonna,
doesn't matter how you get there. Yoke prisms, ponds, hearing aids, you're augmenting this because if somebody has hearing sensitivity, maybe good, well, it doesn't make sense. Why am I going to make this louder? You're increasing the signal. That's what you're doing. You're allowing less confusion. So let's go back here to the research question. I say this is a PhD. I love research, I love evidence, I love data. You're entitled to your opinion, but not to your own knowledge, right? However, we need to look at this. This is a Cochrane review of 154 routinely done medical interventions, which are useful. I'm not saying they shouldn't be done, but the Cochrane review comes back and says, only about 9.9%, so 15 out of 154 had high enough evidence to justify their use according to Quaid methodology. So put succinctly, only 1 in 10 medical interventions have that evidence to justify their use. So we need to be open about what we know and what we don't know. There was a person at the university who offered this statistician. Again, my undergrad was in medical statistics. I know what was I thinking. And this person said there's about 23 different ways that you can screw up a randomized clinical trial. And said, you read any of them, I guarantee you I can find at least 8 on every single one out there. So we need more evidence, but we also need to realize sometimes you don't need to build a spaceship to cross the road. If anyone ever saw, there was a spoof article in the BMJ, the British Medical Journal, on a double-blind, placebo-controlled experiment on the parachute. Anyone ever see that one? And it was like, well, we couldn't find any double-blind, placebo-controlled evidence in the literature that parachutes work, so therefore we shouldn't use them. It was like the most radical protagonists of evidence-based medicine should organize and participate in the placebo group of the parachute experiment. And this is the BMJ. Like, they were literally saying, we're not saying evidence doesn't matter. Of course it doesn't. But do not dismiss clinical experience. What you see in the clinic, 20 years of clinical experience, that matters. If you've seen 1,500 patients, it matters. You see patterns over and over again. That's important to realize. So going back to Ramachandran's work, he basically says, I would add that in science, one is often forced to choose between providing precise answers to pivoting questions, i.e. how many cones are there in a human eye, or vague answers to big questions. What is the self? But every now and again, you come up with a precise answer to a big question, such as the link between DNA and heredity, and you hit the jackpot. It appears that vision is one of the areas in neuroscience where sooner or later we will have precise answers to big questions, but only time will tell. I would have bought the whole book just for that paragraph. It's cool, right? Love this book. If you ever did get a chance to read it as a clinician, ego's the enemy. And what he basically says is wherever you are, whatever you're doing, your worst enemy is already inside of you, your ego. We are just scratching the surface of what we know about the brain. Always assume the other person has something to teach you. Any person I interact with, even if I don't agree with them, I'm listening, because chances are, if they say 10 things and 9 I don't agree with, you're going to throw out one gem that is useful to you in your clinic. And I think if you don't have that mentality, you need to check yourself in the mirror. I'm going to put a QR code up there because I was invited last year at the University of Cambridge. I honestly thought it was a joke. I got a phone call. This is blah, 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 from the University of Cambridge. I thought Cambridge, Ontario, but they had a school. And he's like, no, we're in the UK. Can you come over to a keynote speech? So I went over to the University of Cambridge to do a keynote speech to a bunch of rehab professionals, a mixture of sports medicine, neurology. But they were an out-of-the-box group of thinkers, and I really enjoyed it. So it's actually online. If you scan the QR code, it'll take you right to the lecture. And again, that's going to be in the slides that we send out to you. And I love this quote from Einstein. We're concerned, the man in his fate must always form the chief interest of all technical endeavors. Never forget this in the midst of your diagrams and equations. We get so buried in data and clinic that we forget we're dealing with people. We're dealing with people. I got lucky when I met that optometrist who pulled everything together for me. And only for my parents, my dad was in the military, my mom was a nurse. And they were both just bulldogs in terms of finding solutions. So yes, I'm tainted by my own personal experience, but I also believe it makes me a better man. So again, docs work with others who make you better. The difference between an average clinician and an excellent one is that the excellent one knows when to get other people involved. So I will leave it there and hope for questions. Thank you.
questions? There's no questions? You're kidding me. Oh, there it goes.
I misquoted you, please. So you said that optometrists are not sometimes the best at identifying.
Well, no, I said, I think they are, but you have to find the right ones.
So if you had a patient present themselves to your office,
Yeah.
and they had two vision problems, they couldn't attribute it to anything with the eyes. The standard of care would be to at least refer them to either an ophthalmologist or your family doctor.
Okay, so if you refer to ophthalmology, what are they checking for? Again, great profession, but what are they checking? And I work with them in the hospital environment in the UK, obviously. What are they checking for? They're checking for ocular disease. They're checking the peripheral end organs. Is there a cataract? Is there a retinal detachment? Is there something that explains the symptoms? And I guarantee you, just like at the CT, it's going to be clear 99.9% of the time. And if they find something, probably nothing to do with the concussion. What I would say is, the GP, I'm not sure what they're going to do. Can they do an NPC test? If they have a business question, that's great. What I would say is start with a routine optometrist. There's 2,500 of them in Ontario. There's no shortage of optometrists. So I would refer them and say, look, I'm specifically referring to you because of a concussion. I want to know, is there a possibility of an ocular motor problem? Even if you're a regular rank and file optometrist, you should be able to go, yeah, you know what, the near-corneal convergence is off, stereopsis, depth perception is down, I think this person needs a more in-depth assessment. They will know within optometry who to refer to get a more in-depth assessment. That's a great question. Because even when I worked I worked in Bradford Royal Infirmary in the UK, because I was trained in Bradford. I also clarify, I'm Irish, not English, but I trained in the UK. When I worked in the Bradford Royal Infirmary and in Moorfields, down in London, ophthalmology, after a while, ophthalmology and the ER docs came to me to ask my opinion on stuff. Because like, all my stuff's clear. And again, the ego's at the door. They're like, I'm trying to figure out what the hell's going on with this patient. So I would honestly start with whoever the patient's routine eye doctor is, whoever their optometrist is, start with them and say, hey, before this patient had a concussion last week, they have probably seen that patient, and here's the big advantage, they've probably seen that patient for routine eye exams every 1 to 2 years for quite a while, so you have pre-existing information. Even if it's something as simple as, well, you know, that's weird, the stereopsis or the depth perception's down, it's now 2 out of 10, and it's always a 10 out of 10. These are routine tests that they should be doing anyway. So I want to be clear, I think ophthalmology is a fantastic profession. I got on great with several of the ophthalmologists at the Bradford Royal Infirmary especially, and they are phenomenal when it comes to disease, right? But when it comes to rehabilitation, I would argue it's not their lane. Like, they're not there to figure out, is there a functional deficit? It's like saying orthopedic surgery versus physiotherapy. Same church, different pew. They're both abused. So, I mean, does that answer your question? Okay, very good.
Yep, so who's qualified to do vision rehab? Is there
Well, actually, in
specialization?
Ontario, it's a very good question. In Ontario right now, if you look at the RHPA Act, the optometry act, so this is my experience as a regulator, which is not fun memories.
Okay, you're talking really fast.
Sorry.
As an Irishman.
Thank you.
Slow down.
So, in the RHPA Act,
Yes.
and the optometry, specifically, obviously every profession has its own act. The 1991 Optometry Act lists 3 things that are restricted acts to optometry. One of those 3 is diagnosis and management of ocular motor disorders. It's listed as one of our 3 restricted acts. So, and in fact, when I went to the physiotherapy website, because obviously being a regulator, we interacted with several regulators on a regular basis and wonderful folks. And a couple of, I think it was last year or the year before, there was a clarification that they sent out to physiotherapy, and they actually had it under, is it physiotherapy? Because obviously they had queries from physios, and rightly so, going, hey, I want to do like vestibular rehab, I'm doing visual stuff, like am I crossing some lines here? And what they basically said is, if you are doing something that is either the restricted act of another profession, or there's another profession that can do it at a higher level than you because of their training, you should be referring that patient out. And that's the regulator saying that, not me. And that's not even optometry, that's the College of Physiotherapists of Ontario. So from that perspective, I would say, yes, it is optometry's realm. I think the problem is, and we're rectifying it, is in the US, there's about 500 FCOBD optometrists who are board certified and it's kind of like the American Institute of Balance, Disney.com, where the website is. Like, you refer to an audiologist versus somebody who's an audiologist who's looking for functional deficits. It's different. Like, they're both good. One's not bad, one's not good. They're differently trained. And I would say it's the same thing in optometry. And if you go to cobd.org, there's a find a doctor locator where you can, no matter where you are, you can probably, there's about 50 to 55 in Canada, there's about 500 in the US. But it's growing because more and more doctors are going, oh, yeah, that's really cool. Like, we have binocular vision training going through optometry school, but they never really focused on rehab, and now the profession is starting to evolve where visual rehabilitation really is a postgraduate training, and the regulators are starting to really see that right now, to the point where I just found out today, because I have to run for re-election every 3 years for council for the regulators, so I'm back on again. And what's happening right now is we are actually in the process of changing our standards of care for optometry to say, if as a primary care optometrist, you get a patient in your practice who's got a history of a concussion and they have lingering symptoms, it is now a standard of care that you have to refer to a colleague who does visual rehabilitation for an assessment. It's because, so it's no longer saying it's optional. It's like, hey, if that patient complains to the regulator and we see it was in your chief complaints and you didn't refer, you're in trouble. That's now a clinical standard. And honestly, that sounds harsh, but I'm like, good. But we need to start getting these patients to the proper standard of care. The last question?
It's not really a question.
Sure.
I myself have an acquired brain injury and I've been through the healthcare system and I actually myself advocated because I was at the end of my rope and I actually went to my ophthalmologist
Yeah.
and Chad and then he referred me to
On top of just doing music. Yep.
yes. And there is actually one in Windsor.
Yes, there is. Hansel Wong is his name.
Yes.
Right? Yes, he's very
He is
good.
the one
And he's an
who
FCOE, he's fantastic.
did the assessment, but I put it myself, so I ended up not being able to treatment for it, but I did do the assessment, so there is one.
Yes. So a shout out for Hansel Wong is his name, but he is an FCOE. But again, go to copd.org. There's a box that says board certified. Make sure you tick that box when you do the search.
Thank you very much.
Thank you.